Hi, good afternoon, everyone. My name is KK Yo from the National Heart Centre, Singapore. I'm also the Scientific Chair of the Asian Pacific Society of Cardiology. It is my pleasure to welcome you to the webinar on the Cardiometabolic Syndrome, a joint symposium organized by the Asian Pacific Society of Cardiology and the Pakistan Cardiac Society and hosted by the Taiwan Heart Foundation. Welcome. It's my pleasure to introduce my two chairpersons, Professor Lin from Taiwan and Professor Sumro from Pakistan. You will also see from the program that we have an esteemed panel of panelists and speakers. Professor Harun Baba will be one of our panelists together with Professor Lin Songxian from Taiwan. And our speakers will feature Professor Shahbaz Qureshi, Professor Abdullah Shahab, and Dr. Chen Haomin from Taiwan. Professor Abdullah is from the United Arab Emirates, and Professor Shahbaz Qureshi is from Pakistan. So with that introduction, I bid you a warm welcome and have you take part in this symposium. The speakers will give a 15-minute talk followed by 5 minutes for discussion. And then at the end of it, we will have a discussion over the general topic on the cardiometabolic syndrome. With that, I'd like to hand over to Professor Sumro to introduce our first speaker. Professor Sumro, over to you, please.
So our first speaker is Professor Shahbaz Qureshi. He is based in Islamabad. He is President Pakistan Aspirin Foundation, Professor and Head of the Department of Watim Medical College, Rawalpindi, Head of the Department of Federal Government Postgraduate Medical Institute in past, and he is working as the head of the Department of MBBS Medical College of Islamabad. Dr. Shahbaz Qureshi, please.
Thank you very much, Dr. Khalda, for your kind introduction. I'm really grateful to the Asia Pacific Society of Cardiology and Pakistan Cardiac Society for giving me this honor to talk on the metabolic syndrome and Asian perspective. And I really feel very happy to discuss it because this is a very important topic that we need to address globally and in our part of the world. I have nothing to disclose as far as this presentation is concerned. And what we need to see is what is the epidemiology of metabolic syndrome. And when we look at the globe, we find that everywhere in each part of the world, metabolic syndrome is getting more and more prevalence. In the United States, for example,
Professor Shahbaz,
1/3 of the adults.
Professor Shahbaz, could you please share your screen, please? Could you please share your screen, please?
I thought I did. Okay, I'll try again.
We can see you. देख रहे हैं ना स्क्रीन पर?
I think something has happened because I actually was share. Now here we have this screen share, and I hope that now it is visible.
Yes, it is. You would have to put on presentation mode.
Yeah.
Thank you. Thanks very much.
Sorry. So perhaps I can just take an extra minute. I was talking about the epidemiology of metabolic syndrome, and I was referring to it as a global problem. And in the United States, for example, 1/3 of the population fits in with the definition and criteria for metabolic syndrome, which was agreed to jointly by several international organizations. And the overall presentation, the prevalence of metabolic syndrome in the 80s and early 90s was 25%, declining in early 2000 and then increasing again to a substantial 34%. And this actually coincides with the obesity, which is increasing all over the world. Now, when we look at the metabolic syndrome, we have a number of factors like the diet, physical activity, fitness, socioeconomic status, the birth size, child growth. This is also very important, genetic constitution. And then you have the components of it: overweight, insulin resistance, hyperinsulinemia, abdominal obesity is very important, ectopic fat deposition leading to diabetes and cardiovascular diseases. The metabolics, when we look at the metabolic syndrome, it is not just the conditions I described. In insulin resistance, actually, you can have in systemic inflammation, which is very important. And this actually leads to atherosclerosis. Now, when we talk about the metabolic syndrome, it is not a new phenomena. It was they are present even in 1923. And in 1988, the role of insulin resistance in human disease was talked about at the Banting lecture by Reven in 1988. And when we look at the metabolic syndrome, we have a very important components of hypertension, insulin resistance, dyslipidemia, and adiposity, making a part of the metabolic syndrome. And this, along with the other risk factors like hypertension, obesity, etc., lead to atherosclerosis and endothelial dysfunction, which then leads to coronary heart disease. And this is very important because metabolic syndrome leads to diabetes, to cardiovascular diseases ultimately. And this is what was seen, that in those patients who had metabolic syndrome, you would notice here that the coronary heart disease mortality was much higher, cardiovascular disease mortality in them was high, and the all-cause mortality also was increased in patients who had metabolic syndrome and developed cardiovascular diseases. And then it is not only the type 2 diabetes and the cardiovascular diseases which are associated with metabolic syndrome. You have other conditions like fatty liver, you have polycystic ovary disease. Sleep disturbances are very important in these patients. What has happened is that it has actually, there has been an evolution of metabolic syndrome over the years, when we have come to a stage where we have become couch potatoes, and that is where we have increased our weight, and this has been what is known as the metabolic evolution. So what are the characteristic features of metabolic syndrome? Number one, central obesity. Number two, high blood pressure, very important, high triglycerides. The HDL level is low, insulin resistance is high in these individuals, and the obesity is of a truncal or a central obesity that we see in these patients with metabolic syndrome. Invariably, it was seen in the Indians who, because we share the same subcontinent with them, and in comparison to the Caucasians, we have seen that we have more subcutaneous body fat. When we check it with the folds in the abdomen, we find it is thicker as compared to the Caucasians. Then we also have some hump in the back just below our neck, and then a double chin. This also is one thing which may also signify a high risk for metabolic syndrome in urban Indians, and may be used as a phenotype marker also. Now, what was seen in this research was that in the Indian and the British, if they have the same body mass index, they actually, the body fat is different, 21.2%, and in the Indians, and 9.1% in the British, even though if the body mass index in them was the same. And what we need to understand is that we have to keep a body mass index which is normal less than at least 22. So obesity, metabolic susceptibility, and clustering of these, it's a syndrome. It's not a disease. It leads to diseases. It leads to diabetes. It leads to cardiovascular diseases. You have physical inactivity. In advancing age, you'll have more of metabolic syndrome. You have body fat distribution, adipose tissue abnormalities, etc., which all make they are constituents of the metabolic syndrome. Now, an important point is that the metabolic syndrome in our part of the world, our waist circumference is the one which determines it. We have actually a lower waist circumference as compared to the Western population. It has to be, if it is more than 90 centimeters in men and 80 centimeters in women, it is a risk factor. That is abdominal obesity. Then you have blood pressure, a fasting glucose, which is more than 100, blood pressure, which is more than 130, 85, they then constitute the metabolic syndrome. And this is the ethnic variation that I've talked about, because you have it in the South Asian population, in the Chinese population also it is the same, in the Japanese it is the same. So basically in our part of the world, we have to, our heights are smaller, and we have more of truncal obesity, and we need to actually keep our waistline much less than the Caucasians, and that is how we can avoid metabolic syndrome. Metabolic syndrome actually is not static. It's an evolving progressive disorder. You may have an early metabolic syndrome where it is healthy. A person first is healthy, he gets early metabolic syndrome where there is an adiposity, hyperinsulinemia, hyperglycemia, dyslipidemia, and hypertension. And in the late stages, you will have, as I showed to you earlier on, severe disease in the form of diabetes and cardiovascular diseases. Actually, in 2009, it was that the description of the cluster of risk factors was harmonized, and which so that you had a universal definition of metabolic syndrome. There are other synonyms of metabolic syndrome, where you have syndrome X, insulin resistance syndrome, metabolic syndrome X, etc., and the deadly quartet, which is part of it. So in Pakistani population, we need to have this waist circumference less than 90 centimeters. A woman should be less than 80 centimeters. We must have triglycerides less than 150. In most of us have an HDL, which is low. And the blood pressure, actually, what I will show to you in the data is that nearly 46% of the population has high blood pressure, and the fasting glucose 110. So these are the criteria which, when met, we can say that this person has metabolic syndrome. This is the newer definition according to the IDF, where once again, with a survey circumference, with ethnicity specific values, and then you have raised triglycerides, reduced HDL, raised blood pressure, and raised fasting plasma glucose, then you will be able to say that this person has metabolic syndrome. These are the different definitions according to WHO, NCEP, IDF, and the EGIR. And I think I have alluded to them earlier on. When we take the South Asian area, we find that in Pakistan, for example, according to IDF, we have 40% of the metabolic syndrome. In India, according to the ATP3, but these are all showing the different areas where you have an incidence of metabolic syndrome. Now, a number of studies were done in Pakistan, and this is a very important study, the second National Diabetes Survey of Pakistan. And in this, it was from 2016 to 2017, where it was a multi-stage clustering technique in all the 4 provinces. And the conclusions of the study was that diabetes has reached epidemic proportion and urgently needs national strategies for early diagnosis and effective management, as well as cost-effective diabetes primary prevention program in Pakistan. This is a very important conclusion of the study. These are the you'll see that the urban and the rural distribution of diabetes according to the study, both in men and women. And as the age advances, you will see that there is an increase in diabetes in these people in the study group. Similarly, in the urban and the rural also, this is the distribution according to the age. As the age advances, both in men and in women, it is very prevalent. The second study was about the glycated hemoglobin, the cutoff values as a diagnostic tool in diabetes. It was part of the study. And the conclusion here was that from the second NDSP demonstrated disagreement between findings of OGTT and HbA1c as diagnostic tool for Pakistani population as compared with the international guidelines. HbA1c threshold for pre-diabetes and NDD were lower in this part of the world. So we have to keep in consideration all these things. Then hypertension in the same study to assess the prevalence and its associated risk factors for hypertension in urban and rural areas of Pakistan. This study concluded that 46% prevalence of hypertension, alarming in Pakistan, with its associated risk factors, like, for example, diabetes, obesity. Hence, implementation laws with lifestyle changes, extremely important. Creating education amongst the people, awareness are required on urgent basis to control or reduce the hypertension prevalence. This is to show the prevalence, both self-reported and newly diagnosed, and the blood pressure from the different provinces of Pakistan. You can see that the distribution in both men and women. And now obesity actually, because of dyslipidemia and lipotoxicity and coronary artery disease, ultimately will lead to heart failure. And it is extremely important that we reduce the incidence of obesity. And when we look at the prevalence of obesity in Pakistan in the same study, the conclusion was that the prevalence of obesity is at epidemic proportions in Pakistan. So all this actually is keeping track of each other. Hypertension is increasing or has increased, diabetes, pre-diabetes, and obesity. They all are going hand in hand, is at epidemic proportions in Pakistan, and it is calling for urgent lifestyle intervention strategies to prevent and manage this important cardiometabolic risk factor. And this is what you have, the general obesity and abdominal obesity in all the 4 provinces of Pakistan. Once again, it's shown graphically. Then what about the anthropometric indices in Pakistani adults? What was seen here was that the findings from the second NDSP demonstrated that the waist circumference, this is important, is a better marker than waist-hip ratio and body mass index in predicting type 2 diabetes for Pakistani population. So we have to keep the waist circumference in mind, and this along with the other parameters like triglycerides, low HDL, the other factors which combine together to result in metabolic syndrome. Then when you look at the major risk issue of dyslipidemia resulting in cardiovascular disease, and it was the same study which also studied the prevalence of dyslipidemia, seems to be very high in Pakistan. And here I would just also add that in our part of the world, or in Pakistan especially, what we saw was that the upper limits which have been given by the other societies may not apply here. Even a lower level of total cholesterol or an LDL, prevalence of dyslipidemia seems to be very high, necessitating an urgent call for early screening and effective management through lifestyle intervention at this time is extremely important in our part of the world, so as to reduce the incidence of metabolic syndrome. Now, in India also, we saw that there was an increased incidence of metabolic syndrome, and this is in the urban India, where you can see the hyperglycemia, hypertriglyceridemia, low HDL, and abdominal obesity in urban India. Metabolic syndrome is extremely high in this part of the world. And this is the area where 1/4 of the world population is concentrated. So you can imagine what is going to be the end result of it. And unless and until we take heed now and start with lifestyle changes urgently. Similarly, even in Bangladesh, it was shown that there was a very high incidence of metabolic syndrome. In Sri Lanka also, similar findings were present. Now, when we talk of the metabolic syndrome, what I feel is that actually the drums are beating. We have dysglycemia, we have hypertension, overweight, LDL, which is high, triglycerides, which are there. And this actually is like an acronym, which you can say dholak. Dholak is another word in our vernacular language for the drums. And therefore, the drums are beating as far as metabolic syndrome is concerned in Pakistan. So what should we do to actually try to stem this rot? We need to have a healthy diet. We need to increase our physical activity. Smoking cessation is extremely important. Another very important thing is stress reduction. And this can happen through meditation, through yoga. And then another important point is improvement in sleep quality. You see, you have a diurnal variation of hypertension, of glucose, and also by the hormones which are released by the adipocytes. Therefore, if you improve the quality of life, of sleep also, you will improve or reduce the incidence of metabolic syndrome. And also, the prevention should start from maternal health care and the neonates as far as breastfeeding is concerned. Then the governments in our part of the world should start with societal and infrastructure strategies. For example, there should be a planning of more walking courses so that a healthy attitude is built up. And this should be we should be able to create an awareness about it in our population so that we can actually reduce the incidence of metabolic syndrome and thereby reduce the incidence of diabetes, cardiovascular diseases, which in our part of the world is actually reaching epidemic proportions. So the take-home messages are, in Pakistan, the prevalence of obesity, metabolic syndrome, and diabetes is high and rising, especially in the urban setting. Obesity is a major driver for widely prevalent metabolic syndrome and type 2 diabetes. And the Pakistani population exhibits a very unique feature of obesity: excess body fats, abdominal adiposity, increased subcutaneous and abdominal fat, and deposition of fat in ectopic sites like liver, where you can have fatty liver, muscle, and others. You actually need to improve the muscular strength of our bodies. Metabolic complications in Pakistanis develop at lower value of BMI and waist circumference. And this is true for India, for Bangladesh, for Sri Lanka, for all the countries in South Asia. And therefore, we actually need to take care of this. Pakistanis are especially at higher risk of getting cardiovascular diseases in comparison to the whites, and they have cardiovascular disease at a much younger age. That is important. Now, these are the 6 S's which I want all of us to remember. We need to cut down on salt. We need to cut down on sugar, saturated fatty acids, smoking, sedentary lifestyle, and we need to cut down on stress. And we need to actually identify what we should do as societies for our people who are suffering from metabolic syndrome or who are going towards it and ultimately would have manifestation of diseases from it. And the clock is actually ticking, and what we really have is from symptoms. When a person is normotensive, they start developing insulin resistance, the metabolic syndrome comes in, hypertension and diabetes, atherosclerosis, and finally death. So the conclusion, ladies and gentlemen, honorable chairpersons, is modern hypertension guidelines have focused on strategies, and we need actually to take care of it, that we must control the patients who have blood pressure in our population, diabetes, and we must take care, we must understand that metabolic syndrome in our part of the world has reached epidemic proportions, resulting in diabetes, resulting in hypertension, and combined with dyslipidemia and smoking is causing a havoc as far as cardiovascular diseases are concerned, even at a younger age. I thank you all for your patient listening. Thank you very much.
So we will move to another speaker. Question answers will be in the end of presentations.
I hope I did not overshoot.
We are moving towards another speaker because we are short of time, and we will be having the question answer in the end of session. Dr. Julian.
I don't have any question. Maybe we can keep a question. Maybe at the discussion part, because I will be out of the schedule. Yeah.
Yes.
Maybe we should move on to next speaker. Yes.
That is my intention.
So maybe I will just introduce the next speaker then. Our next speaker is Professor Shabab from the United Arab Emirates. He's the Vice President of the Gulf Intervention Society and Editor-in-Chief of the New Emirates Medical Journal. He's Professor of Cardiovascular Medicine, and I would like him to invite him to deliver his talk from Syndrome X to Cardiometabolic Risk, Clinical and Public Health Implications. Over to you, Professor Shahab.
Thank you very much, and welcome everyone. With the virtual, we say good morning, good evening, because we are in different parts of the world. That's easy, accessible for everyone. Thank you for the opportunity. I think my colleague already covered everything about metabolic syndrome as a definition, and I've tried to focus on syndrome X, or what it's called nowadays, INOCA. I have no disclosure. Just take you through this case, maybe relevant to the metabolic syndrome. Is a 55 years old female with atypical chest pain. That means you have 1 out of the 3 definition for angina. Retrosternal, worse with effort, and disappear with the rest. So any of these one is give you atypical. And the patient got a family history of cardiovascular disease and sedentary life, and already mentioned, all the definitions for the metabolic syndrome patient has got. Already got hypertension, central obesity, high triglyceride, low HDL, HbA1c is pre-diabetic. Just tells you that, again, what is predominant here. Is it central obesity we're talking about? Is it fatty liver? Is it more to diabetic? Where are we heading? Is it early or late presentation, which is again nice to discuss with my colleague earlier. So this is again just refreshing your mind about metabolic syndrome. It's as part of it is X syndrome, which is, I'm going to show you some cases with multiple risk factors, starting with insulin resistance, which is, I think, the major role in all our problems nowadays. And if we're able to control that, I think we can reverse many of the acquired problems. It's highly prevalent, nicely discussed, especially in our part of the world. Our diet, our lifestyle, all heading that way, and the numbers are striking. There are many definitions. I already discussed this. I'm not going to go through this, and also mentioned our guidelines about the metabolic syndrome in 2019. I think is what's relevant here is having metabolic syndrome and then there's at risk of having diabetes. Of course, having diabetes is, that's increased our threefold to having cardiovascular disease. And really, we recently did a meta-analysis, systematic review on over than 200,000 population of at risk of cardiovascular disease. Our prevalence of cardiovascular disease in Middle East compared to the world, we are 10.3%. That, and the world is 4%. That we are more than two times. And if we look at the leading risk factors in this part of the world, are hypertension is 1 and 2. If you look 1 and 2 in UAE or Middle East, they have hypertension, and they have 1 and 2, they have high cholesterol, and of course 1 and 3 they have diabetes. And these are basically telling us where we're heading. And nicely described, we are at this age. I'm going to discuss the cardiovascular disease. So it's actually, we are always looking at the tip of the eyes. We think about, this is what we do in the cath lab, unfortunately. We try to, anything obstructive, we try to open. If not obstructive, we say the patient is fine. We are missing all this coronary microvascular dysfunction, diffuse cardiovascular disease, which really are highly relevant and to the patient and to the caregivers and to the government, because the amount of money spending these patients. This is taking us to the network of the heart. It's not only the 3 major arteries we know. It's not this epicardial is important, which is represent only 5% of the network. Is the 95, which we don't see, invisible. We used to think of, believe in visible things. We should things we just touch, and I think we are going back to the real things, not invisible. And this is what things, and metabolic syndrome and X syndrome, it's really related to all this. When you look, we see with diabetes, we see with dyslipidemia, estrogen withdrawal, those ladies who are menopausal, they're having these symptoms, and because of the estrogen is missing, people with the hypertrophy and so on, myocardial bridge, myocarditis, they have this typical symptoms. So we've been doing great job until recently. Is the cardiovascular disease is being is not improving. That's for the reason already discussed, because the prevalence of incidence of the risk factors are increasing, and of course not to mention the disparity of the management happening in our healthcare. But not to forget, we are missing, we need to have a new way or new approach to the ischemic heart disease or microvascular dysfunction, or X syndrome used to call it. An example here is a female here of middle age, chest pain on effort and rest. This should really, think about something going on. Normally we do a stress ECG, which is abnormal. Okay, we think of obstructive, we do angiography, is normal. Then we say, hey, you have no problem, it's not your cardiac. And similar to somebody coming on several times with the same problem, submaximal, and we don't know what to do with this patient. We say, okay, you're fine, it has nothing to do with your coronary. We look at the coronary is normal, either CT coronary or angio, but we call it X syndrome and khalas. And we used to do that in the past. And I think, with the recent guidelines tell us, there are these patients more than that you think about, they have non-obstructive. Okay, then maybe you see a bit of mild disease in their artery, sometimes clear, nothing there. But these patients has got microvascular dysfunction, or vasospastic angina, or microvascular angina, which we miss. And this is, we call it nowadays ENOCA, and this is based on the latest presentation. So we used to think of the epicardial, big one. This is what conducts the flow, but the one which is modulate and really use the nutrition properly for our cells. These are the myocardial network. And of course, the pathophysiology of that could be structural problem, could be functional problem, could be extravascular. And just to give you an example here of the patient, here a 54 years old male, overweight, it can fulfill the criteria of metabolic syndrome, hyperlipidemic hypertension, again, goes with that, and ejection fraction is normal, risk positive TMT. You look at their angiography, it's normal, and you do this is the microvascular function test, which we used to do. I don't want to go into detail of this. Is this you do IMR and FFR and CFR, FFR for epicardial, CFR and IMR for myocardial function. And this is here, you see an abnormality of that. And this is actually a patient got microvascular angina. And the management of this patient, of course, is, is just to improve their, effort by giving isoprolol, ACE inhibitors, and statin. Another patient who are slightly different, 69, a female, again, look at the weight, obese, hyperlipidemia, fulfill the metabolic syndrome, and atypical angina. You do a CT angiography, is normal, and you do a coronary angiography, is normal, but the stress is abnormal, and you do the acetylcholine, epicardial, this patient goes, both epicardial spasm as well as microvascular dysfunction. So this patient got mixed. So got epicardial, vasospastic, and micro. So need medication here to manage both. Manage the vasodilate the epicardial arteries and work also at the network down. So this patient given a calcium antagonist with, again, focus on medication for the atherosclerosis, like and aspirin. And the third case is a bit, I think we all miss. We see it. This is a 50-year-old male, for last 2 years, episode of chest pain, sometimes with exercise, sometimes not. Vague duration of, when they get this kind of pain. And again, this is the one I already showed you, submaximal. We don't know. We cannot reach the little bit of change on the stress ECG. And you do the angiography, you find a bit of stenosis here and there. If you are in most of the coronary, cath lab, they just stent that. But better to do FFR, which is, again, not significant because it's above 8.8. So you think, okay, fine, you are fine, you have no problem. Again, your pain is not due to the coronary, but you should go further and do a test at the microvascular. And actually, this patient got reduced FFR, CFR, and IMR. And this was, again, both. You got epicardial problem, which is atherosclerosis there, and that's diffuse, and got microvascular. This patient needs optimal medical management. This goes with the ischemia trial nowadays. Ischemia trial is, this is the one fulfill that criteria. This is what we do. So this patient got microvascular angina and vasospastic angina. And this patient is a 41-year-old female. Again, you can see that there's no weight here, no problem. But the patient got a history of diabetes. Again, having a diabetes, it's put you at all the risk of having cardiac disease. Patient got negative for ischemia, and again had the baseline, angiography and ECG. But when you do acetylcholine, it's very significant. So this patient got vasospastic angina, and this patient fulfill the criteria to give something to dilate their arteries. This is what we miss sometimes. We do angiography on a patient and we see myocardial bridge. And you say, okay, myocardial bridge, nothing to do for this patient, just vasodilate and that's it. But remember, the myocardial bridge is another reason for patient to get microvascular dysfunction. And on long term, the bridge get worse. And sometimes we have to unroof this, but most of the time need patient to understand what's the underlying diagnosis, need a proper management, proper approach. Because if you don't tell the patient the proper diagnosis, they will shop around and they get into the anxiety, all the risk, all the the psychiatric problem, as we all know. And this is from the evidence we have nowadays. Orbita, Courage, and Ischemia all tell us, it's not just need to open every obstructive. There's sometimes no obstructive. You think about myocardial coronary myocardial dysfunction. And that's need the management here should be proper diagnosis and proper management. And I've already showed you the guidelines and how to approach that invasively, because you can get real life assessment and real life diagnosis, and patient be reassured, and they thank you for that. So pathophysiology myocardial ischemia is multifactorial. Metabolic syndrome, as we mentioned, myocardial dysfunction may be structural, which I mentioned, or could be functional. And the functional, of course, the predominant one. but really we all need to be, if we take the patient to the cath lab, we should not just stop at the coronary angio. We should go beyond that and have to have a proper diagnosis for our patient. This patient, very interesting. I just want to maybe finish with this case. You know, sometimes we get a patient, we do, they have some kind of angina. On effort, we do a CT scan, which is like, tells you like intermediate stenosis. You know how sensitive CT coronary angio should be, more sensitive than coronary angio itself. But when you do a coronary angio, you see, actually it looks more significant than CT. Why? And we just, if we do go and do FFR on this one, will be significant. Do we stop there? I think that's wrong. This patient should get a nitrate. When you do a nitrate, you'll see there's a bit of maybe focal, but not really significant. When you do a FFR again, is much improved. Okay, so this is a diffuse disease, not just a focal disease. This patient also got, in addition to this diffuse, got also microvascular. This patient needs an optimal medical treatment, no stent, but medical management. So not every focal or not every normal artery we should just say is fine. We should go beyond that. So careful history, as our colleague today said, this is what we learn as a physician. This should be our life, and this is what remain, I think, despite all the technology change. If we spend some and invest some time with our patient, we're able to diagnose most of our patients, and we know where's the underlying problem. So physical examination to know if the patient got metabolic syndrome, and that's all help. And not to forget, you know, when you come to the X syndrome or the NOCA, management is lifestyle, and then, you know, management depends on what is the underlying mechanism. Could be mixed, could be functional, could be structural, but, you know, it's all come through the proper assessment, proper investigations. So coronary myocardial dysfunction is an important chemical entity, directly contributes to morbidity and mortality, and of course to burden on our financial and the life of everyone, clinician, the patient, and their relatives. Worsen outcome for patient with the CAD and MI. Technology has advanced our knowledge of this entity. We used to call it X syndrome, and that's it. But now we are more aware, I think more to learn, of course. We are not saying we have reached we still need to learn, because until now we have limited evidence based on therapy, because what we need is targeted therapy. You know, when we treat, we try to individualize, and we know what to treat. So thank you very much.
Thanks, Professor Shahab. So I think we have a bit of time in this segment. Can I invite our panelists, Professor Harun and Professor Lin, to perhaps ask their questions or provide some comments to Professor Shahab's talk. Perhaps Professor Harun first. Any comments?
Okay. Hello. Can you hear me?
Yes.
Thank you very much for inviting me on this forum. And it is a pleasure to hear these excellent presentations by Professor Shahab and Dr. Abdullah Shahab as well, and Dr. Shahbaz as well. Well, of course, this is a disease which is very prevalent now in our part of the world as well. And as Professor Shahbaz pointed out, that it has become an endemic. We should all be very careful, especially when we go through our patients. We classify our patients into ischemic heart disease, into diabetics, patients with multiple risk factors, and we have got all the scores which show us what are the 10 years and 20-year risk to the patients. But my own opinion or my view is that this metabolic syndrome is a separate category which is encompassing or enclosing all these diseases, metabolic diseases, into one syndrome. And we should respect especially these type of patients who have gone into the territory of this disease. Because this disease may present with few features in the early part, like low HDL, high triglycerides, borderline diabetes, or you can say pre-diabetes picture, obesity, even somebody may not be obese. But if we catch these patients earlier, we will be at a better platform to prevent the complications which will set in, to treat these people, and to decrease the burden of cardiovascular disease, diabetes, stroke, dyslipidemias, etc. So I have learned a lot in the last 1 hour or a half hour from these presentations. And we keep on learning by these webinars. And of course, I will let my other colleague to speak or to discuss whatever he wants to say. Thank you very much.
Thanks, Professor Harun. I'd like to invite Professor Lin to share his thoughts on the preceding two talks, perhaps on Professor Shahab's talk first. Professor Lin, please.
Okay, thank you for two excellent talk. I just have one question because Professor Kiraj raised a very important question about the definition of the different components in metabolic syndrome. As I say, in Pakistan, the fasting glucose should be more than 110 as a criteria for metabolic syndrome. But you raise the local epidemiology data to show maybe the HbA1c maybe for diagnosis of diabetes should be lower than the Western country. So in Pakistan, should we try to lower the fasting glucose for the diagnosis of diabetes, or especially in maybe in the Asian population, these 5 different components may be different from the Western country, not only in the West, but also in the other component. What's your opinion? Thank you.
So, Dr. Shabazz, I think the question was directed at you and had to do with the definitions or the criteria for diabetes, and I think specifically on that in Asians. Would you have any comments to that? From
the question, can you repeat it?
So I think maybe to paraphrase Professor Lin, he's asking, should the definition for the thresholds for diabetes be different in Asians? Professor Lin, I'm correct?
Yes, I think it is. This is absolutely right, because what we saw was that, as I showed to you in the study which was published, showed that the HbA1c and the OGTT levels, they did not coincide with each other. And the fasting blood glucose levels should be perhaps lower than the Western population, as should be the lipid profile also should be considered to be lower as compared to the Western population. And I think that it is similar to what we saw as far as the central obesity is concerned, where you have the waist circumference which is less than the Caucasians or the Western population. So I think the fasting blood glucose should definitely be considered to be lower as compared to the Western population, because of our body size, because of our truncal obesity, and because of our lifestyle also. There is a variation.
Professor Lin, thank you, Professor Shabazz. Can I check with Professor Lin? Do you agree with that?
Yes. I think maybe these 5 components may be defined differently in Asian population than the Western country, not only in the West. Maybe glucose or maybe dyslipidemia should be modified, if possible. Thank you.
I think it is basically the ethnic variations which are there, and we should take into consideration ethnic variations and the race variations.
Yes.
Which are there.
Well, I think there's definitely some logic to that. I guess my main concern is that if we were to say that we would like to have a different threshold or criteria, then we must have the research to have actionable levels to base it on, because without that, we would be, guessing at what the right level would be. And I'm a bit nervous about that, not because I disagree with the notion, but because I'm not sure what the right line is. And if we don't have the right line, then there are a lot of implications downstream. When do we initiate treatment? How do we label people? And how would that affect their subsequent, insurance or healthcare? I think there are certainly multiple levels of consideration. I do think that there is definitely a so-called burning platform for us to establish these thresholds. And that requires a vigorous research. So I would like to again agree with that notion that maybe we need to broaden or consider that conceptual framework shift, but the data needs to be there for us to be sure what the right line is. I think we can come back to this in the discussion later on. Given time, may I ask Dr. Yasir, I see your hand up. Perhaps we could leave it towards the end for the discussion. But at this point in time, so that we can move on, maybe I can invite Professor Lin to invite our third speaker. Professor Lin, over to you, please.
Okay, I'll introduce the third speaker before going to the final discussion. The third speaker will be Dr. Chen Haoming from Taipei, Taiwan. He is presently the director of the evidence-based medicine in Taipei Veteran Medical General Hospital. He is also associate professor of the National Yangming University in Taiwan. The topic that Dr. Chen Haoming is going to talk about, the title is How to Manage Cardiometabolic Syndrome. Dr. Chen, please.
Thank you. Can you hear me clearly?
Yes, that's very good.
Do you see my share slide?
Yes, the slide is good.
Okay, thank you. Dear colleagues, Mr. Chairman, it's my pleasure to share with you the topic about how to manage cardiometabolic syndrome. This is my conflict of interest disclosure. This is the presentation outline. I will briefly introduce the benefit of treating cardiometabolic syndrome and its pathophysiology. The basic principle of the management is to tackle with each component of metabolic syndrome. The first question to answer is that whether reverting metabolic syndrome is beneficial. In this nationwide cohort study published in Annals of Internal Medicine, metabolic syndrome status was followed up by using the harmonizing criteria in the first 3 health screening, S1, S2, and S3. This figure demonstrates clearly that subjects recovered from metabolic syndrome had a significantly lower risk of MASH as compared with those who developed metabolic syndrome during the follow-up or who had persistent metabolic syndrome. There was a clear dose-response relationship not only for MASH but also for all other outcomes. More interestingly, they evaluate the decreased risk associated with the recovery of each metabolic syndrome component and increased risk of the newly development of each component. It is interesting to know that the high BP is the most important risk factor in all outcomes. To manage cardiometabolic syndrome, we must understand first its causative factors. The core of cardiometabolic syndrome is the insulin resistance and central obesity. Other possible factors including genetics and physical inactivity. Therefore, when targeting cardiometabolic risk, we must deal with all these risk factors, which subsequently cause increased risk of cardiovascular disease. This review article summarizes the treatment strategy for each of these important risk factors. As you can see, lifestyle modification plays a very important central role for all components of metabolic syndrome. Now we'll first discuss the strategy to manage the metabolic syndrome, lifestyle modification first. The insulin-resistant atherosclerosis study was a prospective observational study of around 1,400 patients with variable degrees of glucose tolerance. The regular exercise was noted to improve insulin sensitivity and lower fasting insulin level. Another cohort study using the enhanced data suggests that even moderate exercise is associated with a reduction in all-cause and CV mortality. and the association was most robust in hypertensive subjects, although a trend to benefit was also seen at lower BP levels. We have recently published in Journal Hypertension, which investigates the effect of DASH diet. As you can see in this figure, that shows the DASH diet in the low panel plus low salt diet can not only reduce blood pressure, but also the blood pressure fluctuations. There are different dietary patterns for different components of metabolic syndrome. For example, to lower blood pressure, DASH diet or Mediterranean diet with low sodium is most effective. But to reduce lipid and blood sugar and overweight, low carbohydrate diet and low fat diet are more helpful. The National Diabetes Prevention Program is a partnership of public and private sectors working together to prevent the delay of type 2 diabetes. Because of concern regarding its liver toxicity, the triglyceride arm was discontinued. And in the remaining 3 arms, the trial randomized around 3,000 individuals with metabolic syndromes into the placebo, metformin, or lifestyle modification. As you can see, the lifestyle modification and metformin can cause a reduction of diabetes incidence by 48 and 31% respectively. In the previous meta-analysis, by combining the randomized control trial, lifestyle modification consistently demonstrated reduction in newly onset diabetes. The relative risk reduction was around 45%. In our 2015 hypertension guideline of Taiwan, we used the mnemonic SABCDE for lifestyle modification, which stands for sodium, alcohol, body weight, cigarette, diet, and exercise. ADA in 2019 published a consensus statement about the nutrition therapy, which summarized the guide for different dietary patterns. In summary, there is a growing emphasis on the low carbohydrate diet. Weight loss is an important issue, and high fiber with non-starchy vegetable is helpful. There is also an ongoing enthusiasm about gut microbiota. It's been shown that metabolic syndrome is associated with intestinal dysbiosis of gut microbiota. There are also ongoing efforts which try to implement the concept of the management of microbiome in the battle of metabolic syndrome, such as fecal microbiota transplantation and bioacid. So how about the strategy for obesity? In our previous paper, we demonstrate that the presence and progression of abdominal obesity as measured by the waist circumference are predictors of future hypertension. And for subjects with severe obesity, we can consider weight loss surgery. There are 3 major types of surgeries. The middle type, following reduction, is now the most popular one. We can classify the surgery into the malabsorptive or restrictive. The mechanism of the metabolic surgery involves not only the mechanical, but also the change of intestinal hormone. The bilio-pancreatic diversion will decrease the anti-incretin factors in the duodenum, which will cause the increased effect of incretin and the better blood sugar profile. As you can see in this meta-analysis, with weight loss surgery, there was an increased odds of DN remission and the glycemic control. It was shown in the Swedish obese subject study that the surgery group, as compared with the conventional treatment, had better profiles of all components of metabolic syndrome, including weight, blood pressure, HDL, and fasting blood sugar. Now, the recommendation for bariatric surgery is mainly for subjects with BMI more than 35 in Asian, or BMI more than 30 in diabetes, or poor control diabetes subjects with BMI more than 27.5. Next, we will discuss the strategy for high blood pressure. Evidence has been garnered indicating that insulin resistance and the resultant hyperinsulinemia are causally related to hypertension. The interruption of this pathway creates a resistance to the actions of insulin or insulin-like growth factor 1 in stimulating vascular NO. In UK PDS, tight blood pressure control was associated with greater CV risk reduction compared to tight glycemic control. The reduction of BP targets for diabetes subjects was suggested by UK PDS from 154 to 144. advanced study from 140 to 135. And then a cold BP arm attempts to lower its BP target to 120. In the cold BP arm, around 4,700 diabetes patients were randomized into an intensive BP lowering treatment with a goal of around 120 and a conventional 140. There was no significant difference in the primary endpoint between the group. There was a significant difference in stroke between the intensive and the standard BP lowering arms. And the SPRINT trial is the most important landmark study in the recent 20 years, which compare aggressive BP treatment with a target of SBP 120 versus conventional strategy of SBP 140. It has been shown impressively that aggressive BP reduction with BP target at 120 was associated with a risk reduction of 25% for primary endpoint and 27% for all-cause mortality. Later, there was a post-hoc analysis which analyzed a cold study population by SPRINT's inclusion criteria. We call that the SPRINT eligible cold BP participants. Again, the results was consistent with the SPRINT study. The intensive BP control is better. In a recent published large IPD meta-analysis, BPLTTC, subject with or without CVD could all benefit from aggressive BP control. More importantly, the benefit can be seen with BP target down to 120. Therefore, the 2017 ACJH hypertension guidelines suggest to treat the patients with BP more than 130/80 if there is a history of CVD, a predicted 10-year CV risk more than 10%, diabetes, CKD, or elderly. In addition, I would like to emphasize the importance of home BP. As a leading author, we recently published a 2020 Taiwan home BP consensus. Subsequently, we will have an innovative approach that we will change the measurement tool of choice to home BP monitoring. The definition of hypertension in Taiwan now will be 113/80 millimeter mercury based on home BP monitoring or daytime awake ABPM. For subjects with the number of risk factors more than or equal 3, the treatment target will also be 113/80. However, which is the most suitable agent for metabolic syndrome? It has been shown in previous study that ROS blockade was associated with a low risk of new onset diabetes. In a network meta-analysis published by Taiwan researchers, effects of different anti-hypertensive agents were compared. For all-cause mortality, ESRD or doubling creatinine, serum creatinine, ROS blockade based treatment strategy always ranked in the first or second as the most advantageous agent. So now let's move on to the strategy for hypoglycemia. Is lowering high blood sugar beneficial for cardiovascular outcomes? We conducted a meta-regression analysis for the trials including ACCORD, advanced VADT, and UKPDS, which utilized conventional anti-diabetic agents. There is apparently no lower is better phenomenon. However, many novel anti-diabetic agents with minimal hypoglycemic risk have been developed. We recently published a meta-regression analysis in DOM. In the subgroup analysis, stratified by the decrease of A1C level, the lower is better phenomenon is very obvious. In this meta-regression, in contrast to the conventional agents, the lower is better phenomenon is very clear in studies using anti-diabetic agents with minimal hypoglycemic risk. We can even derive the equation that lowering A1C by 1% convert a significant risk reduction by 30% for MAS and 40% for stroke. And we recently update our analysis by including studies published after 2018. The lower is better phenomenon is still very clear. You can notice from this figure, the slope is almost not changed by including 7 more studies. Now let's move to the dyslipidemia. In subjects with diabetes or insulin resistance, we usually observe the increase in TG, small dense LDL, and decreased HDL. The insulin resistance is linearly associated with TG. This table shows the subgroup analysis for diabetes subjects in previously published landmark trials. the risk reduction of CHD ranged from 11 to 25%, which was similar to overall population. In the treat to new target study, there's a subgroup analysis including metabolic syndrome of around 5,500 subjects allocated to atorvastatin 10 or 80 milligram. In the analysis, with or without diabetes, intensive treatment can result in a 30% risk reduction in all metabolic syndrome subjects. So this figure shows an apparent lower is better phenomenon for LDL cholesterol, that a greater reduction in the LDL results in a greater reduction in CV events, especially in secondary prevention and all patients with diabetes, as shown in the red line in this figure. So low is better phenomenon for LDL is true. In the meta-analysis of diabetes patients, treatment with an HMG-CoA reductase inhibitor resulted in a reduced CV risk. The risk reduction in subjects with or without diabetes were similar. So how about triglyceride? In the lipid arm of a co-study, subjects were randomized into the fenofibrate or placebo. The results were disappointing. Lowering TG is not helpful for the 3-point mass. This figure is the summary of the target of our Taiwan Society of Lipids and Atherosclerosis TESLA guideline in different diseases. For primary prevention of diabetes, the target is 100. For secondary prevention, the target is 70. For subject with ACS plus diabetes, a target of 55 milligram per deciliter can be considered. Lastly, let us check the hypercoagulability. Aspirin provides varying degree of CV risk reduction in diabetes patients. In this important meta-analysis investigating the primary prevention effect of aspirin, the use of aspirin is associated with a low risk of MASH, but an increased risk of major bleeding in diabetic patients. Therefore, the 2019 ESC guideline does not provide strong recommendations for antiplatelet therapy in diabetic patients without CVD. However, aspirin may be considered in high risk of very high risk patients in the absence of contraindication. So ladies and gentlemen, in conclusion, I would like to use STANDARD-2 study to finish my presentation. The STANDARD-2 study randomized 160 patients with type 2 diabetes and microalbuminuria to the target intensive multifactorial intervention or conventional treatment. The hazard ratio of STANDARD-2 for primary endpoint in the intensive group was 0.47. By the holistic care for subjects with cardiometabolic syndrome, including A, B, C, D, E, F, their prognosis can be substantially improved. Previous evidence has demonstrated in a convincing way that controlling ABC, the cardiovascular risk can be reduced by 30 to 50%. With this final slide, I would like to conclude that by treating each component, including A1C, blood sugar, lipid to the target, we can greatly improve the outcomes of subjects with cardiometabolic syndrome. Thanks for your attention.
Okay, thank you to Dr. Chen's interesting talk. May I ask the two panelists to give the comments, maybe starting with Professor Lin Zhongxian from Taiwan. Do you have to comment about Dr. Chen's talk?
Okay, thank you for Professor Chen's excellent talk. You mentioned we should treat the metabolic syndrome from different paths, including weight reduction, exercise, body weight reduction, maybe surgery, treat blood pressure, dyslipidemia, etc. Finally, you mentioned the importance of the trial of STANDARD-2 to tell us the maybe combination therapy of different strategies is very important. And as we know, the 5 components of metabolic syndrome include hypertriglycemia and low HDL. Recently, there are some drug targeting the elevation of HDL but fail. But some try using fish oil, especially EPA, may be beneficial for cardiovascular disease. And recently, some promising agents, such as GLP-1 receptor agonist, may targeting in glucose lowering and the body weight reduction, maybe also a promising agent for metabolic syndrome. I think there are some new strategy for this kind of patient. Thank you for your talk.
Yes, thank you for Professor Lin's comment. Maybe Professor Harun Aziz Ababa. Professor Harun.
The
Professor
microphone
Harun,
is, the microphone should be turned on.
Can you hear me?
Yes, we can hear you now.
Thank you very much for inviting me for the comments. Well, it was an excellent presentation, and we learned a lot from it. And as I already before commented, that metabolic syndrome patients should be caught at an earlier stage. And if they are caught at an earlier stage where this syndrome is developing, the patient stands a better chance of decreased complications as well as a healthy lifestyle. So as we have heard this presentation, the emphasis is on that the sedentary lifestyle should go away. It should be avoided. And as it has been recommended that at least 150 minutes of regular exercise per week is what is needed. This is the minimum. It can be increased as well, but this is the minimum. And of course, the dietary lifestyle changes, the DASH diet, these are very important. Decreasing the weight, obesity, definitely may be one part of the metabolic syndrome. So keeping an ideal weight is very important. To control your blood sugar levels so that the hemoglobin A1C should be between 6.5 to 7 or at least around 6.5. These should be the targets in adult population below 60 years of age. In people who are above 60, we are slightly liberal with them. And we give them targets of around 7% hemoglobin A1C or 7.5. Because as all of you are aware, that hypoglycemic risk carries a sudden morbidity and mortality. So keeping in view all these things, we should constantly at stage on blood sugar levels, we should ask the patient to quit smoking, to develop a healthy lifestyle, regular exercise should be advocated, and to keep the weight in the ideal weight category should be encouraged. Because if you lose weight, you lose blood pressure. If you lose weight, you lose dyslipidemia. If you lose weight, you lose metabolic syndrome. So this is what I can, for the moment, say and comment. Thank you very much.
Thank you. Thank you for Dr. Harun's interesting comments. And I will give it back to Professor Yo to start a discussion part. We still have some time.
Thank you, Professor Lin, and thank you to all our speakers for a very, very nice overview and talks on the cardiometabolic disease. I'm going to get the ball rolling, but first of all, I recognize that Dr. Yasir had a comment early on. Dr. Yasir, if you would like, you please make a comment. I of course would. Would you like to make a comment or question, Dr. Yasir?
Yeah, just I've got one question. What would be the triglyceride upper limit, or what we call the highest limit of TG to diagnose or to fit in diagnosis of metabolic syndrome? Is there any criteria, or few numbers are deranged and we can say it's a criteria is fulfilling?
So maybe I'll ask Dr. Shabazz to take that question. The question is, what is the TG level that would fit the metabolic syndrome?
According to the definition, I think the question is very relevant. According to the definition, when you have a waist circumference, which is 90 centimeters in men and 80 centimeters in women in our part of the world, HDL, which is less than 40 in men and less than 50 in women, and TG more than 150. That is the criteria for it. Because as the TG levels go up, it's not that you have to have TG levels at 400 or 500 to diagnose them as metabolic syndrome. But when you have three of these criteria met, you have a patient with metabolic syndrome. And then earlier on, when Professor Yeo was mentioning about the threshold, if you remember, I had actually alluded to one of the studies of the NDSP, the National Diabetes Study of Pakistan, where the HbA1c level was at about 6.7, which showed diabetes and pre-diabetes as compared to the Western population. But I totally agree with you that we need more data on it, and we need to have more studies in our part of the world to show us as to what should be the optimum levels, because obviously when you diagnose somebody with diabetes or pre-diabetes, according to the newer definition or newer levels, there will be a lot of implications there. So I think that's a very, very valid point, and we should keep that in consideration. When the last presentation actually was very good, and it was as regards the management of it in the different aspects of it. Now, a very important part of the management of metabolic syndrome is the lifestyle intervention. What I want to start the ball rolling in this direction is that what societal and infrastructural changes we as nations can bring about to encourage lifestyle changes, number one. And number two, somebody with metabolic syndrome, how sustainable are the lifestyle changes in the different parts here? For example, in Singapore, how it would be in Taiwan, and what are the rest of the areas people are doing as far as the implementation? Because what I think is that people would sustain it for 2 months, 6 months, or a year even, but then they will start going back into the old habit. So lifestyle changes need to be addressed on a very long-term basis. It's actually lifestyle means throughout life. And this is what we have to impress upon our patients. And a very important part of metabolic syndrome and the management of our patients is what Sir William Osler said, that you need actually to listen to the patient. When we are with the patient, we need to discuss it, how to manage them, what to do. And I think that is an extremely important aspect of it, because there are two stakeholders in it, the doctor and the patient. The patient must be aware of what his condition is, what are the chances are that he's going to get into diabetes, he's going to get into cardiovascular diseases, because the mortality there is going to increase. So I think let's discuss the lifestyle interventions also as in addition to the medical management.
So thanks, Dr. Shabazz, and thanks, Dr. Yasir, for your question. So I agree that our society needs to change, how do I put it, influence how our patients and our population views these lifestyle changes. You mentioned Singapore, and as many of you know, Singapore does have a government that takes an active role in its population's well-being, and we have the war on diabetes, which literally the government declared war on diabetes. There are very active measures to encourage people to take the stairs and walk. There are parks In many cases, our politicians go running and put photos themselves running. So I think government does make a difference. Secondly, I think professional societies like the Pakistan Cardiac Society in hosting this webinar is taking an active role in encouraging our population to, and our practitioners of medicine to encourage its people to lead a healthy lifestyle. I think that's terribly important. Government alone will make it, a society, professional society alone will make it, and certainly we need our people to take an active step. So I think your emphasis is spot on, much more important than what we can deliver as drugs, for drugs and other therapeutic agents. Having said that, I want to ask Professor Lin and Professor Cheng a question about therapeutics. The American Diabetes Association just had a nice paper presented on a twincretin weight loss agents together with semaglutide or other GLP-1 receptor agonists. So, it's hard to get people to exercise, eat well, and pray and meditate and do yoga. How about if we just give them a pill, give them, or injection in this case, a GLP-1 receptor agonist and make them lose 10 kilograms. So maybe I'll ask Dr. Cheng, how would you comment to that? Is that a magic bullet?
Yeah, thank you for this very good question. Actually, I because of time limitation, I don't have time to present the novel agents such as GLP-1 agonist and SGLT2 inhibitor. Actually, they are very important in dealing with the metabolic syndrome. And I think both of these two strategies are very important. They can be done in patients together. So like SGLT2 inhibitor and the GLP-1, they both can reduce body weight. And from the animal studies or human studies, they analyze the components of the body weight loss is on the lean mass rather than is on the fat mass rather than on the lean mass. So actually, they can reduce the intra-abdominal, visceral abdominal fat rather than the subcutaneous fat. So I think the new agents, especially like GLP-1 agonists, they can some of them have the indications for body weight reduction. So they can be very promising in the future. But we still should emphasize the lifestyle modification, because lifestyle modification can not only reduce body weight, they can also reduce the blood pressure and also the inflammation. So I think physical activity should be encouraged. And in the future, probably some new the new anti-diabetic agents such as GLP-1 agonist or SGLT2 inhibitor can have their role in the management of metabolic syndrome.
Yeah. Thanks very much for that comment and for your thoughts, not just on the GLP-1 receptor and agonist, but also on the SGLT2 antagonist. To Dr. Shahab, I would like to ask, in the UAE, does the government take an active role in encouraging a healthy lifestyle, and is there something we can learn from your part of the world?
Thank you very much. I think that's a very important question, and I'm not maybe the right person to answer this. Is normally the government to answer this. But as a physician, we always try to, the problem with any meeting I go to, you try to talk about what role of the government. I think what should be role of our physician. I'll come to that, to your question. I think role of physician, as all we said, is really the relationship with our patient to start with. We invest first visit with them, because that's where we lose them. They don't trust us. They will not take anything from us. You're talking about lifestyle modification, lifestyle. We prescribe medication very nicely. We say 3 times a day, this is the dose. Can we prescribe lifestyle? If we're able to do that, then I think we are doing the good job. I think the government in UAE started to do a great job. Actually, they provided the places where they can exercise. They helped with a diet. The vegetable, fruits, and some of the nice diet are supported by the government. There are lots of encouragement, awareness for our patients. These kind of things we expect from the government more, of course, and more. But I think metabolic syndrome, it's really is a moving target. Every time they change the definition, the prevalence increases, you know, and you notice that happen to hypertension, diabetes. But you know, we need to focus on diet, you know, improve our diet. Stress, you know, that's the amount of stress we have as a physician. Look at us, you know, our life, very stressful life, but we can change it to passionate, you know, to be more passionate in our, you know, in our work. I think if we look at ourselves, then that will be reflected on our patients. Thank you.
I think
I have a,
can I just make a couple
yes, of course, Dr. Shabazz, please.
You see, when we are talking about lifestyle intervention in our patients, we need to be very practical. Number one is that it is sustainable only if the patient becomes a party to it and agrees to it. And number two, sometimes you cannot expect a patient to start running 3 to 5 kilometers every day, like my dear friend, Professor Harun Babar. If he goes to the gym and exercise, you won't find many patients doing that, or giving up smoking completely, or having a diet which is very healthy. So I think what we need to do is to have a modest reduction. We should be more practical when we are talking to our patients and gradually build them up. And then they will be able to probably accept the lifestyle changes, which they can then adopt. But I'm really very happy to see that in Singapore, and to know from Professor Yeo that in Singapore you have a very good commitment from the government to actually start with the lifestyle changes. And this is something which is needed in most of our countries. And it is also needed, for example, to actually reduce the population. We are 1/4 of the population of the world here in this part of, in South Asia. And we need to actually reduce the population also. This is also very important. And we need for that a lot of commitment from the government. I had been in the government sector for about 45 years. And I tried my best to convince the politicians who would come to me and to ask them to pass legislatures for it. But unfortunately, it could not be done. We passed a legislature on no smoking. And in every government office, I would go, who would be smokers, they would continue to smoke. And if I was to tell them that this is something which is against the law and you are going to be fined 1,000 rupees for that, and they would tell me that they have put the notice on the back of their on the back wall, and so they don't see it. You see, the government commitment is extremely important, and I think Pakistan Cardiac Society, Professor Harun Babar, the president, they can try to take a lead role in it. We need to actually change our approach towards our lives. We need to actually have a very healthy lifestyle.
I think it's what we hope to do is never easy, and as they say, anything that is worthwhile doing is never going to be easy. I would like to take a slight twist to the discussion, and perhaps this would be the last question. And I want to ask Professor Sumro, in regards to the metabolic or the cardiometabolic conditions, do you think that in women there is a specific gender aspect that we should be mindful of? Could you share your thoughts on that, Professor Sumro?
Because he showed us many cases of cardiometabolic syndrome. Talking about the Pakistan, we have different conditions in rural and urban areas, which is more common in our conditions are more likely to the other South Asian countries like India and Sri Lanka. They all have the same conditions, socio-cultural conditions in which we are living. But comparatively, India and Sri Lanka are having much better educational level and awareness in the women. In our part of the Pakistan, our women are having more suffering from the metabolic syndrome, because especially if we consider the urban area women, they are having more problems, stressful life, and they lack of exercise, overwork, and they don't have physical work in urban areas. But in rural areas, women is comparatively, despite of the lack of awareness and the lack of the education, they are much better than the male partners in those areas. And as we know that our socio-cultural values usually don't allows us to follow the lifestyle, ideal lifestyle modifications in this part of the world. That's it.
Thank you, Professor Sumro. And I think we are right on the dot at well, 6 p.m. Singapore time. Again, I'd like to thank all our speakers today. I'd like to thank the Pakistan Cardiac Society on behalf of the Asian Pacific Society of Cardiology, all our speakers, chairpersons, as well as panelists for doing this wonderful session. I think this is a very, very relevant topic for our community in Asia. And with that, I'd like to close the session and again, thank the Taiwan Heart Foundation for hosting us on their platform. Thanks very much and have a good day, everyone. Thank you.
Thank you.
Thank you very much. Have a good day.
Thank you.